I'm Shelly Horton. I'm a journalist and I'll be hosting this Patient Voice Initiative series. Now, most of us have no idea how the health system works, least of all how decisions are made about which treatments the government subsidises to make them affordable. And you know what? Most of the time, knowing how it works is not a priority because we can access the treatments we need with the Australian government subsidising more than 1 million medical services every day through Medicare and discounting the cost of more than 80% of medicines that are prescribed. But when someone wants to access a medicine or service that's being considered for subsidy, especially new and innovative treatments, knowing how the system works can make a difference. Patients, their loved ones, and the organisations that support and advocate for them can help decision makers make more informed choices about what is subsidised on Medicare and the Pharmaceutical Benefits Scheme. You just need to know a bit about the process and how it works, and how patients and patient groups can usefully add to the process. In this video, we will cover the basics of how the system works and how your knowledge can make the system work better. I've gathered a crack team of professionals to help break it down. First up, we have Jessica Bean. I first met Jessica at a health conference I was hosting, and I was blown away by her story and her positivity. She has cystic fibrosis, and at 21, she was told she'd need a double lung transplant. She said, no thanks. And 10 years later, she's still using her own lungs to speak up for patients' rights. Jessica's experience as one of the first cystic fibrosis patients to benefit from genetic modulation therapy gave her an intimate understanding of the challenges faced by patients in the age of personalised medicine. This inspired a mission in her to ensure patients and their values are represented in decision-making across the health ecosystem globally. She's a patient advocate, international speaker, consultant, and empowerment coach for young women living with chronic illness. Please welcome the ray of sunshine that is Jessica Bean.
Thank you so much, Shelly. What a pleasure to join you today.
Next up, it's Simone Laden. Simone lost her sister Kate to a rare cancer a decade ago. She saw firsthand the huge disparity in treatment and support options for rare cancers compared to more common cancers. Determined to change that, Simone co-founded the Unicorn Foundation with her brother, Dr. John Leyden, to raise awareness of neuroendocrine tumours, also known as NETs. And that needed to be raised amongst members of the public and also the medical profession. The foundation, now known as NeuroEndocrine Cancer Australia, is the only Australian not-for-profit dedicated solely to seeking a cure for NETs. Currently, over 10,000 Australians live with NETs, and even this year they're expecting another 4,900 people to be diagnosed. Simone advocates for greater access to treatments and diagnostics, raises funds for the NET Nurse Support Service, and funds clinical trials and research. Please welcome the unstoppable Simone.
Hi, thanks for having me.
We also have Dr. Simon Pfeiffer joining us. Simon is not a medical doctor, he's a doctor in choice. He literally got his PhD about decision making, so he knows how important choice is to patients. His research into patient preferences can help build health systems that better meet patients' needs. He describes himself as a pracademic, that's a practical academic, with research focus directed at solving real-world problems that make a major impact on society. He's a fabulous presenter and I can't wait to chat to him, so please welcome Simon.
Thanks for having me.
And finally, we have Anne Single. Anne believes learning from patients and their families is essential for good healthcare, because even with robust evidence, there can be gaps. Those gaps might prevent new treatments being used in ways that offer outcomes that really matter to patients. Her passion in this area began 20 years ago while directing communication and patient involvement for Scotland's first health technology assessment agency. She now chairs Health Technology Assessment International's Patient and Citizen Involvement Interest Group, which brings together more than 400 people internationally to push for practical patient involvement. Please welcome the lady with the rose gold headphones, Anne.
Hello.
Thank you all for taking part. Anne, I'm going to start with you. Why does the government subsidise some health services and medicines in Australia and not others?
Well, I guess it all comes down to having fixed budgets and governments wanting to invest in those health treatments that are regarded as good value for money. So really what governments, and it's not just the Australian government, it's around the world, what they try to do is work out which health treatments are going to be the best value for money. And by that, they're trying to think about what's going to have the most impact in the Australian community.
And how do they decide if something is subsidised or not?
Governments around the world use a process which is called health technology assessment. And really all it is a type of policy research which tries to work out if something's good value for money. They look at all the evidence, mainly from randomised controlled trials. They look at economic models and they look at safety. And from that, they try to determine whether it's going to make a real difference to patients in Australia.
Why do you think patient groups should get involved?
Yeah, I think it's really important to consider the type of medicines that we have coming through the system at the moment. I think they're so innovative and work in ways that we haven't seen treatments work before, that it's more important than ever that we're capturing that whole picture of impact, the whole picture of what treatment does for a patient.
Look, I think it's really important for patient groups to get involved because we are at the forefront of speaking to patients all day, every day. We can understand their lived experiences with what they're going through, but also, especially in a rare cancer that we look after, or a less common cancer, if you like, there isn't one size fits all. So when you're looking at health technology assessment, they really would like it to be that one system or one medicine actually will suffice for many, many people. But we know, being at the forefront of conversations and experience, that it isn't like that, and that every single patient is potentially very different. And so we need to get that nice balance and ensure that the voice of that patient or that patient group is included when they're looking at what some sort of medicines will actually be effective, or whether they actually want to endorse these medicines as well.
What information can patient groups usefully add to the process?
Well, we've in the past looked at all sorts of things such as surveys, but I think most importantly is sharing the story of the patient. So how does this treatment, this test, this diagnostic or this device, how does this actually affect the patient's life? And it's looking beyond just what the clinical data is showing. We know that sometimes what is shown in the data and what can be seen as, whether it's not very great progression-free survival, we know that actually in a real experience with patients, that could mean the difference between having access to a medicine that allows them to see their child's next birthday. It allows them to walk their daughter down the aisle. This is actually getting into how does this affect a person, not just what does the data actually show. And I think that as a community, we need to be really a lot more mindful of, as we know that we're going to be living with cancer or living with diseases for much longer, not necessarily curing them, but what can we do to improve patients and the community's lives by sharing those really, really important stories?
Yeah, I think that one is really depends on the disease area, and it can be quite unique. But overall, I think that the things that matter to patients can't always be measured. And in more traditional evidence, they are those endpoints that we measure that are more clinical based. The things that patients know about their disease, about living and treating it, they're the things that we can capture with patient-based evidence. Things like the impact that your condition has on family members and loved ones. Can they work? Do they have to have time off work to take you to appointments? And how much of a commitment are going to those appointments. Also, the little things throughout the day, the little things that add to that big picture, things like pain, organisational factors. How long do you have to spend each day or each week organising your medications, ringing the pharmacy? And what about your quality of life? How do you feel when you wake up of a morning? Do you have fatigue?
And how can patient groups provide input?
There's a couple of ways. They can provide a consumer comment, which anyone in Australia can provide, and that just is any comment you want to make around medicine that's being assessed. Patient groups can also make a submission to PBAC or MSAC.
Now, PBAC, MSAC, what are they again?
PBAC is the Pharmaceutical Benefits Advisory Committee. So they're the people who advise the government about what's good value for money that could go on the Pharmaceutical Benefits Scheme. So those are our medicines. And the other group is MSAC, which is the Medical Services Advisory Committee. And if you think of that as most of the services you'll get on your Medicare card, they're the people that advise the government about those services. So if you want to provide information to those groups, patient groups can do that by making a submission. They can make a consumer comment. And sometimes those submissions may be an amalgamation of all the members' views. For example, a patient group may have contacted their members and asked for their views around a medicine, or it may be the result of some research they've commissioned.
So why do some groups actually do research to support their input to the medical bodies?
Groups are often doing research because there's a lack of evidence. Often in the case, it's a lack of a local Australian-based evidence. So there might be things overseas that they could use, but the PBAC and MSAC are really looking for local-based evidence. And it's often in situations where that outcome that they're going to make are very important to those particular groups. So they need to put evidence in to support that particular decision.
By doing research, I guess then we can try and compare apples with apples. But I think there shouldn't be too much of an expectation that clinical or that sort of research is vital for the patient organisations, but I do think that it allows you to have a seat at the table. It allows you to show evidence that can be easily understood by the system, if you like. But I do think also that anecdotal research, so the information of the patients and how they experience their healthcare system or their drugs is also of vital importance. But definitely, we do that research within the neuroendocrine cancer space because it hasn't been done before. So we need to actually start the narrative and explain the disease from the outset. So the research is important in that space where other information isn't available.
What sort of research can you do?
So we have in the past done some surveys, but for us, we have just developed in conjunction with our healthcare professionals, who are a fantastic group of very collaborative people with us. We have developed a tumour registry, but also a patient app that actually feeds the quality of life data directly into the registry.
There's lots of different types of research you can do. You could probably break it down into two groups. Qualitative research, which is often case studies and patient stories to talk about patient experiences and what's happening for people living with the condition. And then there's quantitative research, which is more like patient-reported outcomes and patient preference studies, often to do with surveys that we develop.
Previously, we've relied on research and information that happened years ago. We wanted to develop something that happens right here and now, so we can be making the best decisions right here and now.
Well, that's about all on how the system works. Thank you to all of our experts. Next up, we'll be explaining a bit more about patient-based evidence. I'm Shelly Horton, and thanks for watching.